Hello, I'm Matt Ewan. I'm the Chair of Neurosurgery at the University of North Carolina, and I'm the Director of the Brain Tumor Program for the University of North Carolina's Lineberger Comprehensive Cancer Center. Today I'd like to talk with you about what we term metastatic brain tumors. These are tumors in the brain that have spread from somewhere else in the body. Today I would like to talk with you about metastatic brain tumors. There are two main types of tumors that occur in the brain. The first are tumors that started in the brain. These are called primary brain tumors, or gliomas. We've created a separate video to discuss those. The purpose of this few minutes that we'll spend together is to talk about tumors that have spread to the brain from another form of cancer. Usually this comes from lung cancer, breast cancer, melanoma, kidney tumors, but it can happen from any sort of cancer. Many patients who are diagnosed with a metastatic brain tumor are already aware that they carry the diagnosis of a brain tumor, but about 10% of the time, the tumor in the brain will be the first presentation of the cancer, even though the cancer itself may have started elsewhere, such as the lung. There are probably about 25,000 patients in the United States every year diagnosed with primary brain tumors. In contrast, there are probably between 100,000 and 200,000 people every year with cancer that spreads to the brain, these metastatic brain tumors. And what I'd like to discuss today are the treatment, prognosis, and options for patients who are diagnosed with a metastatic brain tumor. People often ask me about metastatic brain tumors and who is at risk for developing them, or who is a typical patient who might get one. It really depends on the kind of tumor that we're dealing with. For breast cancer, the typical patient would obviously be a woman, and certain subtypes of breast cancer, such as the triple-negative breast cancer or the HER2-positive breast cancer, are more likely to spread to the brain. Likewise, melanoma and lung cancer have a propensity to spread to the brain, so patients diagnosed with lung cancer or with melanoma will get more surveillance for brain spread than patients with other types of cancers. I meet many patients who develop metastatic brain cancers. There's two main pathways that they come through, or that the tumor is diagnosed. The first is that some patients will be undergoing surveillance of the brain. If they have a certain type of tumor that has a high risk of spreading to the brain, they may get an occasional CAT scan or MRI of the brain looking to see if any brain tumors have developed. These patients will have their tumors found what we call incidentally, meaning they haven't developed neurologic symptoms or headaches, but rather that we were checking with a screening test and found the tumors. The other group are people who develop neurologic symptoms. Because the tumors grow in the brain, the metastatic tumors, both by the size of the tumor and by swelling around the tumor, can produce neurologic symptoms. This can be weakness, speech trouble, headaches, vision problems. Anything that the brain does can be affected by a tumor that grows up in that particular area of the brain. In a patient who has cancer and develops a neurologic symptom, a brain tumor that has spread must be suspected and evaluated immediately. Many of my patients who have metastatic brain tumors are under the care of an oncologist who specializes in treating their lung cancer or their melanoma or their breast cancer. And that physician may be monitoring the patient for any neurologic symptoms or for new findings on a CAT scan or MRI scan of the brain. At the time when a brain tumor is found, that patient may be referred to me as a neurosurgeon or to a radiation oncologist, and the three of us, the medical oncologist, the radiation doctor, and the neurosurgeon, will work together to find the best treatment plan. For most patients, MRI is the workhorse of making the diagnosis. It shows us the brain. It will pick up almost all tumors that are larger than 3 millimeters, and it will show us the location, the size, the amount of pressure, and very importantly, the number of tumors. When we choose a treatment for a patient or recommend a treatment to a patient, the key variables for us are how many tumors are there, and obviously the fewer there are the better. 1 is the best number. The kind of tumor that has spread there, lung cancer, breast cancer, melanoma, how big they are, is there any sign of bleeding from the tumors, has there been any swelling, and is the patient having symptoms? And we use all of those factors together to recommend the best course of treatment for a patient. At the time the diagnosis of brain metastases or new tumors in the brain is made, it's important that the treatment team take into account the patient's situation in regard to the tumor outside the brain. Some patients will have had no sign of the tumor growing for many months or many years, and the growth in the brain will represent a new phase in their treatment. Other patients may be undergoing active treatment for the tumor either at its original site or at other areas in the body where it's spread. As I'll explain in the coming few minutes, the treatment for the tumor in the brain may be different than the treatment for the tumor elsewhere in the body, and you can expect that you may have one treatment strategy for the brain component and a different treatment strategy for the tumor elsewhere in the body. And it may even be someone like me, a neurosurgeon, is guiding the brain component and is partnered with a medical oncologist who is guiding the treatment of the tumor outside the brain. The important thing is that these two members of your team or multiple members of your team are in constant communication so that the treatment is the best treatment for your entire tumor and not just the tumor in one site. It's very important at the time the brain metastases are discovered that you and your treatment team talk about all of the treatment options. I always think my role as a doctor with an interest in brain metastases is to explain all of the options with the advantages and disadvantages of each, and then to give the patient a particular recommendation of one or two or three of the options that appear medically perhaps to have a higher success rate. Let's talk for a minute about what the different treatment options are. Essentially, I think there's 5. One is to watch. In certain patients, we'll find a very small dot of what might be a tumor, and we may decide that the best thing to do is to do very close follow-up. This isn't often the case, but it certainly should be considered for every patient. I wouldn't use that for a patient with a large tumor who has a lot of symptoms from their tumor or for whom we need a diagnosis. But in some of my patients, the amount of tumor that's there is very small, and close follow-up may be an observation, may be a good option. The second option is surgical removal. You may think as a neurosurgeon that we recommend surgery for everybody. And surgery is a good option for a subset of patients, but it has to be very closely personalized. The patients who usually would go for surgery are ones who have 1 or maybe 2 tumors rather than many tumors, and for whom one of those tumors is causing a lot of symptoms. So a large tumor that was causing speech trouble or weakness could be removed, the tumor could be treated, and the symptoms could improve. That would be an outstanding or an excellent time to recommend surgery. Other patients have multiple tumors or tumors in unfavorable locations, and we would probably use other treatments besides surgery to treat those. Surgery should be considered, but often there'll be other less invasive methods that can be used. There are 2 forms of radiation that are used to treat brain tumors, and they're slightly different in how they're done and in the types of tumors that they use. I'd like to spend a moment and explain the 2 of them, and then try to put them in context in terms of which patients might benefit from one or the other. One type of treatment is called stereotactic radiosurgery. It's a big word. What it talks about is very focused radiation. There are 2 machines that do this the most, called the Gamma knife and the Cyber knife. They're sort of like the Coke and Pepsi. They're the most common forms, but there are many companies that make machines that do radiosurgery, and they're all pretty effective in treating this. I rarely find that the key issue is deciding which brand of machine to use. I find it's much more important to decide whether focused radiation, this radiosurgery that I'll explain in a moment, is the right treatment or not. The other kind of treatment is called whole brain radiation. The major difference between radiosurgery and whole brain radiation is how big the target is and how many treatments are given. So radiosurgery is a very precise treatment. I ask my patients to think of a bicycle tire and to think of every spoke on the bicycle tire as a beam of radiation. The axle, which sits in the middle, would get a big dose of radiation because every beam intersects it. But the rest of the brain, which is the rest of the tire, will get very little radiation because there's just a thin line here and a thin line here. Radiosurgery is a very precise treatment of a single tumor, and it's very effective at treating that tumor, but it does not provide protection elsewhere in the brain because all of the radiation is focused on that one spot, the axle of the tire. Whole brain radiation is almost the opposite. The entire brain, the whole brain, is treated with radiation. This is usually spread out over 2 or 3 or even 4 weeks, and that allows the normal brain to tolerate the radiation. The radiosurgery is usually given on a single day, occasionally on 2 or 3 days, but it's very targeted. So let's just summarize those two things. Radiosurgery treats a single tumor in a single day, and it works very well for 1 or 2 or maybe 3 tumors. Whole brain treats the entire brain, and so if there are multiple tumors, 10 or 20, it will treat all of those tumors. Whole brain can also treat tiny little seeds of tumor that are too small for me as a doctor to see on MRI. Sometimes we give both. We give radiosurgery to treat the tumor we can see, and we give whole brain to protect from other tumors. The decision to choose between these two types of radiation or use them together really requires you sitting down with a radiation oncologist and often a neurosurgeon who does radiosurgery and deciding in your particular case what's the ideal strategy to control the brain. Some people worry about giving radiation to the brain and potential side effects, but I always try to remind them that the thing that worries me most is tumor growing in the brain, and that successfully treating the tumor in the brain is usually the best way to make sure that the patient feels well and maintains a high quality of life. Very often the tumor that a patient is diagnosed with, the lung tumor, the breast tumor, the melanoma, is being treated with chemotherapy. And patients ask, why can't the chemotherapy be used to treat the tumor in the brain? After all, it's the same tumor, it's just spread to a new place. The answer is, sometimes it can. The problem is that the human body has walled the brain off with something called the blood-brain barrier. I always think that that was put there so that if we happen to eat a bad mushroom, it might keep that toxin from getting into our brain, but can also prevent chemotherapies that are given as pills or given as infusions from getting into the brain. And so the tumor cells can, in a sense, hide behind the blood-brain barrier. It may be hard to reach them. Whatever chemotherapy is proposed to treat the brain tumor, the medical oncologist who's to give that chemotherapy needs to make sure that that particular drug can cross the blood-brain barrier. Some can, and some can't. It obviously would make no sense to treat a tumor inside the brain with a drug that doesn't cross the blood-brain barrier. And this is why you may find that you're getting one chemotherapy to treat the tumor everywhere in your brain, and then getting radiosurgery or whole brain radiation to treat the tumor in the brain, because the brain can't be treated with the chemotherapy drug. Other times the drug will work in the brain, and it may be that all of the tumor everywhere in the body can be treated with a single drug. Obviously that would be ideal, but unfortunately it doesn't always happen. Many patients who have cancer and are told that the cancer is spread to the brain worry about new side effects that they might encounter because of the involvement of the brain itself with the tumor. Certainly, the treatments that are aimed at the brain have potential for side effects just like any other cancer treatment. And those side effects relate to the part of the brain that's involved. So if there's swelling around a tumor in the brain that's close to the movement area, the patient can develop weakness in the part of the body that's controlled by that area of the brain. I always try to counsel patients that the thing we worry about most are not side effects from surgery or radiation, although we do worry about that, but we worry about the growth of the tumor in the brain. There isn't a lot of extra room inside the skull, so if the tumors in the brain grow uncontrolled, they'll very rapidly cause new neurologic symptoms. Successful treatment of the tumor, with radiation, with surgery, with chemotherapy, lessens the chance that we'll get neurologic side effects from the tumor. So we always have to balance the potential side effects of the treatment versus the side effects of the tumor growing. Usually the goal that we all have to treat the tumor will be the path that leads to the fewest potential side effects. The discovery that a tumor has spread to the brain, even in patients who already were aware that they had a diagnosis of cancer, certainly causes a lot of worry that this could represent a escalation in the tumor, that it could be at a higher stage or growing more rapidly, or that the patient's outlook is dimmer than it was. This is certainly a very serious diagnosis and often requires immediate and very active treatment, but it's not a hopeless diagnosis. You should discuss with your doctor whether the discovery of tumor in the brain changes the outlook for your tumor. I have many patients who've been diagnosed with breast cancer or lung cancer that spread to the brain who have done remarkably well for many years. But we also see patients where the brain treatments or the treatment outside the brain doesn't work as well as we would like. This is a serious addition to the diagnosis, and it's very important that your treatment team explain with you what it means for your long-term outlook. We continue to focus on controlling the tumor in the brain, keeping our patients feeling well, active, involved in things that bring them pleasure, and choosing treatment strategies that both prolong their life, improve their quality of life, and improve their outlook as they fight their cancer. Even for patients who already carry a diagnosis of cancer, the development of a brain metastasis, a spread of that tumor to the brain, can be a very scary proposition. There is hope for patients who are diagnosed with brain metastases. The treatment that I've discussed today can be very effective in controlling the tumor. Unfortunately, this is certainly a serious part of your treatment and may require immediate treatment or a change in your treatment plan. I encourage you and your family to discuss this with your healthcare team, to listen carefully to the treatment options and choose the one that's best for you. There are organizations like the Guideposts of Strength that can provide you with information, with patient and family mentors, and with other resources that can be very useful as you go along your journey for cancer. I wish you good luck